Great. Thanks very much. It's nice to be here. Thanks for asking me to join you. And I'm going to speak to understanding the role of trauma when providing education to care for infants with NAS, the benefits of involving mothers. So the first, I'll say two things about the title. First, I will interchangeably use NAS or NOWS or neonatal withdrawal. There's some current work underway about terminology. The second is that when we talk about mothers, of course, we're also talking about partners and families. So to be inclusive of our broad families that we're working with. Okay, I'm just fiddling with my screen view here. That one doesn't let me progress, you guys. They helped me with my screensaver before. So I'm going to go out. Oh, there we go. I think I got it. Okay, I am good. I just want to disclose that I don't have any conflict of interest related to this presentation. So the way we're going to organize our hour today is I've organized the first half to look at an overview of trauma-informed care. I know there's been a lot of work done in many of states related to looking at trauma and integrating that approach into working with families. And then I was going to take the second half of our hour and extend that concept of trauma-informed care within an integrated framework of other theories that inform trauma-informed care. It's going to, I think, expand our toolkit of approaches that we can put into play. So that's how our time is going to be organized. I will look at the chat as well. Charisse will help me. So I'm quite happy to take questions as we go, and also a little bit of time at the end. So I apologize if I talk too fast, because that's what I tend to do, because it's all interesting. So for those of you who might not know me, I'm from Victoria, British Columbia. And British Columbia is the westernmost province north of Washington State in Canada. I live on Vancouver Island, which is that island over there on the left in the capital city called Victoria. So it's a lovely place to work. I've lived here for many years. I have been a registered nurse since the 80s, and I've probably been interested in this area since the mid-90s, when I started working with our child protection unit here in the province. We had a case where a mom who was using methadone, her baby was placed in foster care, and the baby was shaken. And there was a big Children's Commission review here in the province looking at supporting infants in care. And that's how I first became more interested in this issue. And before that, frankly, I didn't pay a lot of attention. I don't know how old our participants are here today, but I did my neonatal specialty programs in the late 80s and early 90s. We really weren't talking about this issue at all. If we saw some jitteriness, we would often attribute it to many other differential diagnoses and not really think about substance use. When I moved to Victoria, again, Victoria is very close to Vancouver. Vancouver is a port city. There's a lot of drug inflow and outflow in Vancouver, but it's also a very innovative city. So a lot of the early HIV work done in Vancouver has been very cutting edge as far as treatments. And the same with substance use and looking at innovative approaches to dealing with substance use in the population in general, and specifically related to women in pregnancy. And if you've been reading in this area, you might have heard of a program called She-Way, which is an integrated wraparound maternity care model. Or you might have heard of Fur Square in BC Women's Hospital, which is a hospital-based program for women with substance use issues. So we've had the real opportunity to learn from the clinicians and researchers working in these programs about how to do this work differently. And where I live in Victoria is actually a smaller community. It's still a big city of about 500,000, but a conservative more city, not really well resourced with supports and services related to substance use and mental health, which has been a real direction we've been growing for the last few decades. So in Victoria, I've had a few different roles. I worked as the perinatal lead for our health authority. And one of the myths I had about substance use was that it was a big city issue. And certainly when many of you here might be from smaller, more rural communities, and this is an issue that's touching us all in rural and remote and large urban settings. So if we think about our families today, and I can say that this is certainly true here where I live, and you can think about your communities, that our families are growing in diversity, complexity, and family arrangements. And in some literature, you'll see no norm is the new norm. So many, many different family constellations. And we are seeing, of course, we're reading a lot about this in the media about the increasing inequities related to income. So a lot more families who are dealing with many social challenges. Here where I live, housing is very, very expensive. So it's very challenging to find good housing, especially if you're a family. And we are seeing substance use, violence, increased acknowledgement of mental health challenges also. Of course, we've seen over the last few decades more mothers who are working, and not just because they want to, but also because you often have to have a two-income family to support what you need for the cost of daily living, and all those childcare issues and maternity leave issues that come along with family concerns as well. So families are dealing with a lot these days, and this is broadly, let alone families who are layered on with substance use challenges. What we're seeing in health trends too, sometimes framed as the new epidemiologies of childhood. And I think back to when I was in nursing school many years ago and all the things I learned about like asthma and allergies. And now we actually did a survey here on our island of our I looked at the data for child health, and what our pediatricians are starting to see more and more and more are developmental issues, mental health issues, lots of chronic health issues. So really seeing the epidemiology of what our families are dealing with health-wise changing as well. And of course, that comes into the neonatal units that we're working within. I'm anticipating many of you are here from the NICU, but feel free to chat in also. Many of you might be from public health or social work. It'd be great to know who you are so I can speak to a few questions. And I see somebody has just chatted me that you used to live in Victoria in 2008. Yes, it's growing. It's continuing to grow. So our populations, of course, and when I started working in the neonatal unit in, I will say, the late 80s, really was about premature infants, the great variety of congenital anomalies. We were supporting infants who had a bit of a tougher birth and needed to kind of settle in a little bit. But now a whole different group of population that we're looking at are prenatal substance exposure. And when I was involved with the Vermont-Oxford Quality Improvement Collaborative, we were hearing from NICUs who had a very substantial percentage of their population that were infants withdrawing from opioids. So why should we be trauma informed in our perinatal and neonatal services? To step back to any parent who's entering our clinical environment, the health issues they're experiencing are not expected, and that can be traumatic in and of itself. And the hospital environment, which we often take for granted because we are kind of immersed in it, is definitely a frightening environment for our families. Layered on top of that are the complex social challenges that they're dealing with. And the final point for us to acknowledge too, that when it comes to substance use, we are often challenged ourselves to be empathetic and non-judgmental. And so that's some personal work we all have to kind of go through to bring our best selves to our practice with very diverse families. So I'm just going to get into a little bit of the background on trauma-informed care. And I see Becky is a psychologist in North Carolina. And first of all, I will declare I'm not a trauma-informed expert, not a psychologist, not a therapist, but I am an interested clinician who has sought out learning in these areas and seen the great value and how it can enrich my practice and bring me in a better way to the families that I'm working with. So that is my perspective I'm bringing. So a little bit of brief background about the concept of trauma. Of course, those of us who are health providers, we often think of physiological trauma and car accidents and things like that. But when it first, the brief history of when it first started to be applied from a mental health perspective was the early ideas of neurosis and hysteria. And of course, those were probably more likely to be applied to women than men. First suicide hotline at the turn of the century in San Francisco. And really when people started to think about trauma was the shell shock from World War I and World War II. But it was often linked to not being a strong soldier. And the treatment was to just get right back to the front line. And of course, there's much more acknowledgement of that now. and of course into the DSM-3 as PTSD in 1980. As far as applying the concept of psychological trauma to women, really it was probably in the 70s and 80s where we started to see the second wave of feminism, and really some more public awareness about domestic violence, intimate partner violence, family violence, and people being more open to speaking about that and realizing that it was a much more common experience than previously thought. And we'd started to see the language of battered women and battered child syndrome in our legal documents. And so that great awareness of child abuse also at the same time. These are a couple, if people are interested in this field, these are really kind of some of the foundational readings. If people are wanting to go away and kind of look at the roots of the approach. But this approach came from the field of psychology, and Judith Herman's book was really a landmark book in 1997, focusing on recovery and thinking about how to move past those traumatic experiences and seeing the connections between the biological, psychological, social, and political also, which is interesting. But we tend to have that dichotomy between biological and psychological. So really starting that conversation that we're really talking about now about those close intersections. Harris and Fallot really pioneered the notion of trauma-informed services, and their book, Creating Cultures of Trauma-Informed Care, is still a good read to look at to get those foundations. And then people started to have developed, like Elliott and their group, principles for trauma-informed services that have continued to be developed. That's not a long history, really. And I'm thinking about, a couple decades. So those of us who've been in healthcare for a long time, sometimes the developments in different fields don't necessarily translate into our neonatal field. And so I found I've been doing a lot of reading outside of health to then bring that into my practice. And psychology is one of those fields, as well as women's health, kind of gender perspectives, mental health, and substance use. So the go-to definition that a lot of sources are using right now is from SAMHSA, Substance Use and Mental Health Services Administration. And for those of you who might be newer to some of the mental health and substance use learning, it's a great site to go to look at the different resources that they have. And in particular, in 2018, they have clinical guidelines for working with women who use substances during pregnancy. And that's a great go-to resource for a lot of information. But their basic definition of trauma is that it's the response that happens when an event, a series of events or circumstances is experienced by an individual as physically or emotionally harmful or threatening. Sorry, that's supposed to say as, not because. And it can come from early life experiences. It can come from more recent life experiences. But the balance is that it's overwhelming that individual's capacity to cope. So it can be an individualized experience. So someone might say, well, I experienced this in my background and I'm fine. And it's very individual because of these different capacities that people might have. So that's probably the definition you'll see in a lot of resources. And here's a couple of the documents that they have available. And I've started to smatter, I went searching for Texas-related documents from a trauma-informed perspective to integrate. And some of you might know of other local resources as well, so feel free to chat those into the side there. But SAMHSA has identified 6 principles of trauma-informed practice. So if we think about what these principles might look like from the perspective of someone who has a substance use background while they're pregnant and trying to access the services that they need, that whole notion of safety. So if you've experienced trauma in some way, you bring that experience to when you're accessing other services. So thinking about where you practice and how it might feel like it could be safe from a physical safety perspective, from an emotional safety perspective, a cultural safety perspective, and thinking about your services and supports. And I'm going to smatter actions and activities all the way through the talk rather than just identifying some at the end. So often a first step that teams do is to look at their service and space from a safety perspective. And are there ways that that environment can be made more engaging, more open to very diverse populations. Second principle is trustworthiness and transparency. So being able to come to a conversation in a trustworthy way. And if you think about someone who's experienced trauma, they may have great difficulty in trusting someone. So that might be something that has to develop over time. So, for example, one thing we know from research is that when you're in doing prenatal care and asking that very sensitive question of tell me if you've used any substances while you're pregnant, if you've not got a trusting relationship with that client, they're most likely not going to be open to sharing that very sensitive information with you. And it might be only over time as you get to know them and they get to know you, and you've proven yourself to be open to hearing where they're at and supporting them where they're at, that a little bit different information might get disclosed over time. Peer support. Again, an approach that many women serving programs are taking is to have women with lived experience be part of the practice team. They have great insights to bring to how to do things better, and also contribute to that environment and sense of safety as well. Collaboration and mutuality, working together. We tend to, of course, not realize this as much as we probably need to, but as health providers being in a different situation of power. And so automatically we're in a place where we may have a power over relationship with our clients. And so really trying to set the stage right away for how can we work together, and how their voices are important, just as important, if not more important, in setting up what we need for them at that time. Empowerment, voice, and choice, really creating those circumstances for input. That also goes to our programs. So if you think about who you might have a parent council in your programs, but think about who's on your parent council, and often it may not be people who have a number of challenges in their life because it's really hard to get to meetings and participate. So thinking about how you can get at that voice and find that voice and bring it into your planning and work in a different way is also a great strategy. And finally, the last principle is cultural, historical, and gender issues. And I can just share a Canadian experience, and you can all think about what might be experiences in your state and your communities. But here in Canada, over the last number of years, we had a Truth and Reconciliation Commission a number of years ago now, acknowledging the historical impact of colonization and residential schools with our Indigenous and First Peoples. And so we are working a lot in health education, for example, on ensuring that our future nurses and doctors and other allied health professionals have a good understanding of what's happened to communities from a historical and intergenerational perspective, because the impacts are passed on intergenerationally. So it's important to also think about how this work is situated in your communities from those perspectives. SUNTA also identifies the 4R elements. They love to have a catchy 3E and 4R, but they are helpful kind of mnemonic to think through some steps. And so we'll just walk through the 4 steps of realizing the widespread impact of trauma, recognizing those signs and symptoms, how we can respond, and then how we can seek to resist re-traumatization. So realizing, of course, is step 1. So if your team is new to thinking about how could we engage with the concept of trauma-informed care, the first step, of course, is to do some learning together as a team and thinking about what the incidents might be in your community, what the contributing factors might be in your community, those root causes. But PTSD is certainly in the literature increasingly being linked to a number of health concerns during pregnancy. So you'll often see higher rates of high-risk behaviors like tobacco and alcohol use, higher comorbidity with depression and obstetrical complications. So of course, you think high-risk behaviors like tobacco and alcohol use, sometimes the chicken and the egg, as far as sometimes substances are used to cope with the trauma that people have experienced. So we may be recommending that people reduce their alcohol and tobacco use, but we may not be helping them think through, are there other things that they can be doing to deal with the trauma that they've had. So you can't necessarily just take away what they had to be dealing with that experience. The prevalence, this is from a 2017 study. So if you look at a general community sample, about 3.3% PTSD. And if you look at higher risk samples, and that would be associated with people who might have a substance use history, for example, you can see that it's substantially higher, 1 in 5. So trauma is a fairly common experience for our families. And so that's why you'll often hear, why couldn't we, let's think about a universal precaution approach to trauma. So you don't necessarily have to ask everybody about specific trauma and deal specifically with that trauma from a kind of a prenatal obstetrical perspective, but you can be sensitized to the fact that many of your clients, this may be a part of their experience that they're bringing to you. So to be aware and then have strategies to support that. So in the neonatal unit, also especially, we know that mental health challenges are common for all our parents in the neonatal unit. There is increasing literature on the incidence of stress PTSD for our families. Either they're coming with that experience, or the NICU experience itself creates the trauma. And we think about what our families are dealing with. This first book by Gottfried and Gator was about 1985, I think. So we have been paying attention to the issue of infant stress and parent stress, but really thinking that through a lot more these days, and also thinking it through for ourselves as team members. And so when you're constantly dealing with a lot of challenges related to infants who are really ill and families who are struggling and grieving, that's hard for us as providers too. So an important part of the trauma-informed approach is to think about how you work as a team to process experiences so that you can be working together and moving forward as a team. So trauma-informed approaches are most effectively implemented when you can do it as a team. And if you think about that safety and security that families are looking for, it's hard for families to read different providers. So who's going to be a provider who's going to support me today? Can I trust this provider? Versus doing this work and developing this competency and strength as a team. And recognizing the effects also, not just for the families in front of us, but also thinking about in our communities and society. So, and it's just, I don't need to put COVID on this slide, but we have had a lot coming at us as providers, as communities, and we'll be kind of coming out the other end, but we're going to have some effects on our mental health and well-being as communities that we need to consider as well. That connectedness, imagine how we've lost some of that connectiveness and collective support, even through having to stay home. And how is trauma experienced and expressed? And there's a lot of writing on this slide. You can kind of go away and look at it, but where I found this helpful as a clinician is to not take at face value some of the ways our clients come to us in conversations or discussions. So it helps you understand and look beneath some of we might see families who, just to simplify things, might be really upset or yelling or calling names. And that's hard for us to take as clinicians, but I find it's really helpful to be able to look beneath that and think about what might have put this person in a place where that is the way that they are expressing how they're feeling. So it's another way to help you interpret the behaviors and life stories of our families. And so how can we create a trauma-informed environment? And I love this quote on the right, and the sanctuary approach. You can read a lot about the sanctuary approach, but it's really looking at that environment as a whole, collectively as a team. And also, how does your organization support developing trauma-informed perspectives? Here where I live in Victoria, our major health authority is starting to implement trauma-informed approaches as a core value of the organization, because they're acknowledging that it's a system-wide need for us to practice in this way. And so here's just a couple ideas to kind of start out with around creating that trauma-informed environment. And first of all is just thinking about how are new team members invited into your environment? What are the values you share with them about your practice together? Is trauma-informed care kind of a fundamental perspective, just like we talk about family-centered care, and we talk about developmentally appropriate care? Where does trauma-informed care fit into the foundations of how we work together with our families? Thinking about providing opportunities for debriefing for the team after complex scenarios. We don't often have the time or space or ability to do that, but there may be some different and creative ways that we can do that, so we're not just moving right on to the next set of circumstances and unpacking some of the more difficult experiences that we've had. And these things, if there's any managers online as well, these are all factors that affect things like staff retention. We want to hang on to our team, so we want to keep our team well, and being able to debrief from complex situations is a really important part of that. Providing opportunities for learning and building of skills. If you're looking at we're not talking about past trauma-informed care today, but if you look at some of the strategies that are increasingly being used in substance use and mental health fields, like different types of screening approaches or brief intervention approaches, motivational interviewing, are excellent techniques, and those are ones that we can learn and practice together as well, and very effective for this population. So seeing our skills, our relational skills, as critically important, as well as our psychomotor skills and so on. Setting that welcoming tone when families arrive, and that integrated response from everybody, right from and when the doors open and families are invited into our environment. What is that like? There's actually some interesting tools I've had my students do as part of community health classes, as far as walkthroughs. If you go online, you can look through organizational walkthroughs with checklists, so you can be reflecting on how this might feel for your clients. You could actually do this collectively from like patient care co-design approaches to have your parent groups also help you walk through and what works or doesn't work from their perspective for creating that welcoming and safe environment. Using strength-based and person-first language. So that might also be an interesting activities to go away and just kind of be a fly on the wall in your workplace and hear about how families are talked about. And I know that was a bit of a moral distress situation for myself sometimes, where a family might leave and then they're talked about in a different way, which is an awkward place to be put into, particularly if you're a newer clinician. So thinking about how can we come together to reflect on how we are talking about or representing families in our conversation, because it trickles into our care practices as well. So it's important to be mindful and reflective of those. And again, just because we're talking about being trauma-informed doesn't mean the expectation is there for us to launch into trauma-specific treatments. And we have some clinicians online who would be doing trauma-specific treatments. But for us as general healthcare providers, is just to think about how we can embed that understanding in all our aspects of service delivery, even the policies that we have, for example, and placing that priority on that safety and the choice of the control, which is hard to do in acute healthcare environments. Again, in responding, we went through SAMHSA's 6 principles earlier, but I thought for responding, I would just line them up here with family-centered care, which is an approach that we all take in our practice in neonatal and family care settings. And you can see a lot of connection to the principles. So what I'm essentially saying is here, if we're delivering good family-centered care, we're already most of the way there to really be delivering good trauma-informed practice. And so there's a little bit more consideration and understanding of some of the principles from substance use and mental health, but really starting to see those family-centered concepts as important to trauma-informed practice also. Now, every now and then I'm going to lean over and check my watch because I tend to go over time. So I'm going to do that every now and then. So even thinking as far as resisting re-traumatization. So if you think about women who, if you look at the literature around substance use, a very substantial majority of women have experienced physical, emotional, and sexual violence in their past. I know we went and did a site visit at our Vancouver Women's Prison here in the province a number of years ago, and 100% of women that were in that environment had experienced sexual abuse. So when you think about how that might sensitize you from a physical safety perspective, how can we create an environment then that feels safe for women? I put pictures there, for example, of a door. You can imagine that door would feel like it would trap you. So you have to think a little bit of a different way from people who might have experienced violence in their lives, for example. So my final slide before I kind of get into the second part is thinking about trauma as the tip of the iceberg, and it's what we might see in practice, but there's a lot that underlies what we see in practice. And so I'm just going to spend the next half hour introducing you to a couple other concepts that really kind of underlie trauma and also inform some further strategies that we can use with our families. So I'll tell you what neuroscience is in a minute, but we're just kind of going to go into that beneath the trauma. So this is a mini historical review of how we looked at brain development. And turn of the century, we didn't think much of what babies' capabilities were. So we didn't expect a lot from babies, and we didn't do a lot with babies. And that is, oh, I haven't got my slides here. I need to, I'm having, is anyone else here menopausal? I shouldn't say that here, it's going to be taped, but there we go. Oh, Darwin, Charles Darwin. And he wrote some interesting observational books about his own children and starting to look at what their capabilities and capacities were. So we weren't really doing a lot with babies at that point. Some of the studies that started coming about in the 50s and 60s, and some of you might remember this classic image of the monkey with the fuzzy carpet robots, so to speak, testing attachment and how attachment develops or doesn't develop. Ainsworth's strange situation. So if you've looked at some of the early childhood literature, the ones where mums leave their babies, or Tronic still face, where mums are very engaging and then mums make their face and affect flat to kind of test babies' responses. So starting to then realize that babies are connected in a different way to the people and the environment around them, and highly responsive. And of course, we all know that very well. This is a really classic book that came out from the Institute of Medicine in 2000, so over 20 years ago, From Neurons to Neighborhoods. And this is from an AAP committee on integrating the science of early childhood development, and really starting to bring that science forward. That was letting us know how the brain and development of the brain is highly dependent upon experience. And so that's when you started seeing those brain images of the brain on the left that had lots of connections, and then the brain on the right that did not. We started hearing about the Romanian orphanages and infants and young children who were raised in an environment that didn't have a lot of stimulation. So starting to think about what that meant for attachment, what it meant for families and parents. This is a great site to go to as well, the Center on the Developing Child through Harvard. And they have spent a lot of time on working to translate the complex brain science into helpful concepts that you can use. I've used their material when I've been doing talks on supporting your infants in mom centers. And so very useful information and resources to share with families and our communities. So these are a couple of the models that you might see in the literature through pediatric organizations, early childhood organizations. So you can see how they're starting to take a life course perspective and thinking about how our early life experiences, which also includes the prenatal environment, then create the circumstances for our future health. And so there's a lot more research now looking at how early experiences whether that's toxic stress, that cumulative burden of challenging situations, then impacts our health in later life. This was from a 2012 pediatric statement. So, all of these have, it feels like they were just released, but they've been out now for quite some time. And so you can see they're really starting to integrate life course sciences, ecology, thinking about the impacts of the physical environment and the social environment, and starting that increased awareness about epigenetics. Many of us, of course, who were in school a long time ago would have been taught, and that kind of the public thought is about nature versus nurture, but knowing it's a lot more complex than that. So it's a very interesting science emerging, and depending on your practice background or how long ago you graduated, some of this might be newer information. So we're starting to integrate this, for example, into our undergraduate nursing programs in their pediatric courses. So here's a couple frameworks you might start seeing. I chose NEAR, that's the one at the bottom, but there are many others, and what these frameworks are attempting to do is to put together these complex bodies of knowledge that are really exploding related to brain science, trauma, adverse childhood experience science, and kind of because they all intersect. So, but the things they share, no matter what approach, you might have heard of some of these, or your states might engage with one or another of these frameworks, but they're all attempting to get at the root causes of these challenges and flip from seeing things as problems to seeing how we can build strength in our individuals, building strength in our families, and building strength in our communities, and break that cycle. Recalling, of course, that in trauma-informed literature, a lot of trauma can be intergenerational. So really thinking about how to disrupt that continuation. So why is it important to have an integrated framework? Well, the issues that we're dealing with, sometimes you might see them positioned as wicked problems. They don't have one straight answer. Many of us here online today might work in a particular area, or you might work with a population where all populations are experiencing all of these challenges, and trying to find a way for the growing science to come together and help us make sense of these very complex social issues and health issues, and come together beyond our usual kind of siloed health and health practices, social care practices, putting it together from a community-based perspective to support our families in a different way. So I'm just going to use the framework of the NEAR science just to very quickly walk you through these 4 areas of neurobiology, epigenetics, the ACEs science, and resilience. And if any of you are dealing with these or working with these, integrating them into your practice, feel free to start chatting some of this, your experiences with this into the chat. And of course, I am not an expert in any of these. I will say this twice, but I find it really helpful to inform when I'm developing teaching documents or parent support documents. It's great to be able to integrate some of these concepts. Of course, we know a lot more now than we used to about the neurobiology of stress and the biological systems that are involved in that stress responsivity from a hormone perspective. And also thinking about allostasis, how all of these biological systems work together, and increased allostatic load as far as when the stress gets repetitive or to such a level, there's not a chance for the stress systems to back down, and stress keeps accumulating. And then you start getting to that elevated risk of disease because your body doesn't have the chance to settle down. If this is from the Harvard Center for the Developing Child and some of those materials, but you can see stress is a good thing, and we need stress to grow and challenge ourselves and learn. And there's a certain level that we can tolerate, but there's also a point where it gets to be toxic, where we just can't cope with it and back it down anymore. And so a lot of strategies in trauma-informed counseling are about helping clients be mindful about stress, where they're sitting at stress-wise, and strategies to help them reduce stress. And that stress as a caregiver. So if we, think about our parents that we're working with, and that intergenerational notion of stress, and if our clients are experiencing toxic stress or stress that is just not being relieved for them, that then rolls down to their own children. You can see how the intergenerational cycle starts, not just from a social perspective, but also from a biological perspective. Just a little bit about epigenetics, and we'll see where our science takes us, but it was thought, of course, that the differences we saw were inherited. And so that's where we ended up seeing with mental health, for example, a lot of mother blame. And so if a child or an adult had a mental health challenge, they would say their mother did not attach to them. Their mother was cold, and that's some of the literature you would read from decades ago. And then, of course, as science started to develop, we had different ways of testing some of these approaches, MRIs and so on, learning more about how the brain connects, how the brain is impacted by social conditions. So then it can tip the other way as far as, so now we're in, there's epigenetics, where we know that the genetics themselves can be impacted by the environment within which somebody is living and growing. And that's where the stress mechanisms come in. So these are complex physiological processes that underlie some of the trauma literature that we are reading. Resilience is the R, and this is the capacity of a dynamic system to adapt successfully to challenges that threaten their functioning. And we can apply this concept at multiple levels, but certainly we could think if we applied it for an infant, and what helped an infant and a young child become resilient, or a family unit, or a community. Anne Maston, Michael Unger are some of the researchers who have done work for decades in this area. And a couple of the key concepts related to resilience is that how can you create circumstances where the protective processes or the strengths overlay the risk processes, so that you can build up those protective strengths, even though some of the risks are still there. So someone might live in a very low resource community, but you could build in some of the different supports and programming that provides different opportunities for children and families as a protective mechanism. And I like the notion of resilience because it's strength oriented. We tend to often go to problems and problem solving versus flipping that around and thinking about what strengths are our families bringing with them. And in fact, many of our families are highly resilient because they've had to cope with many challenging environmental issues and experiences. And sometimes what we see as behaviors that maybe we might interpret as inappropriate are actually strength and coping behaviors that they've developed to make it forward in their daily living. So resilience is a nice concept to think about from a family perspective, because it helps us look at a family and a child and go, let's talk about strengths first, and let's really support those. An interesting way to frame this regulatory capital, but it's as far as promoting, we talk about how infants, a very important job is to develop regulation capacity so that they can manage those ups and those downs. And so how do you support infants and families to develop that regulatory strength? And it's developed over the lifespan. And I think when you talk about early years literature, one of the challenges is that can make you think that you've got this moment in time you have to really pounce on and grab and focus on. But in fact, we continue to develop these capacities throughout the lifespan. So we can be working with families and parents to continue to think about how to develop their strengths. For example, I work with the program Nurse Family Partnership. You might have that in Texas. And one of the goals of that program is to build self-efficacy in young mothers, in first-time low-income young mothers, so that they can then take that through the rest of their lifespan as parents and women. Attachment and belonging in your families, but also in your communities. And so there are different ways you can build those protective processes. There's a little bit of literature coming out now about protective processes in pregnancy and birth and early childhood. So that's some interesting literature to read as far as, for example, Gagnon and Stewart have started to look at how parents and researchers would define resilience in the perinatal period. And you can see here those phrases like getting through a situation, coping, bouncing back, overcoming problems. And so how can we kind of stack the deck in the supportive side versus the punitive side? ACEs science, many of you might have heard of ACEs science. There's certainly a lot more awareness, and I will put a slide up at the end as far as some Texas organizations. But ACE is the Adverse Childhood Event Study that took place in the 90s in California. They looked at a big HMO and a large number of participants, and looked for what they called adverse childhood experiences, which could be things like witnessing violence, parents experiencing a divorce, and so on, and looking at how common those experiences were across the population. And they found that 1 in 4, 25% were exposed to 2 categories of ACE, 22% sexually abused as children. So, almost 1 in 4 of their clients sexually abused as children, lots of family violence. So I think this really was kind of an eye-opening study that's had a lot of grip, and people are following up on and starting to look at their own communities. And again, there are, it's that early life stress we were talking about, the early adversity that then has a cumulative impact and across the life course. And so the more adversities you have and accumulate, and for longer periods of time, the higher the probability that you're going to see that impact your functioning in adulthood. So there is a lot of kind of rollout. The important thing also is it's not universal. Again, there is individual, and that's where those resilience protective experiences can come into play. This is an interesting model because they stretched the ACE and talk about a pair of ACEs. So the tree at the top is those adverse childhood experiences that they were measuring for. And underneath that, this is where you can start to see looking at the community environment. So they're looking at adverse community environments that could include poverty, discrimination, community disruption for different reasons. There's literature, for example, on if there is an economic downturn in a community, the incidence of family violence and child abuse goes up. We're already hearing anecdotal, and I'm sure there'll be lots of research coming out about the incidence of violence or some of these adverse community environments changing with the pandemic as well. So we'll be hearing lots about that. And this is actually a really interesting tool you can go on and download, and you can add some of your community data to build this picture for yourselves. And this is actually really helpful infographic way to work with your community partners to think about where could we focus some resources to develop resilience, to develop protective programs and services. So some of you might be interested in going away and building that picture for your community and working collectively with your community. This is the 3rd level. So we started with ACE 1 and then ACE 2, and this is ACE 3, where they're taking it up even further to look at the environment and look at climate issues, for example, wildfires, and how that is going to further impact strengths in our community that then impacts families. And of course, right now, many of us are living in very hot areas and looking at, water scenarios changing and so on, so, and how that impacts our family health. So that's right down from the micro up to the macro, which can start feeling a little bit overwhelming. But as a team, you can think about, finding your place to start, what's important in your particular community, and start there. Just a couple places to find data if you're, again, looking to build that picture for your community. The Annie Casey Foundation has done this Kids Count data report annually. So this is their last report from last year. I just put the red arrow to Texas, which is number 42, and they look at a selection of different indicators over time. So that's a place to go and look at how your state or your community is doing over time, and then think about what might have impacted those changes. This is some literature from Texas as well, where some ACEs scoring was done. And so you can see here what your prevalence is here in your state, as far as 55% of adults in your state having at least one ACE, and then increasing from that point on. And you can get a sense of what your communities or individuals are dealing with related to substance use or physical abuse. This is some Texas data for age 0 to 17. And so, you can see that a third of your younger population are experiencing economic hardship, where, for example, they might not have enough food on the table. And you can see when it comes to substances, about 10% living with anyone. It could be a sibling or a parent or a family member having a problem with alcohol and drugs. So it gives you a little bit of a picture for yourself. But there's a lot of data that's out there to actually kind of find and build your picture. And of course, as we said before, with these cumulative impacts, they actually have a rollout when you think about allostatic load and wear and tear on chronic disease like cancer and diabetes. So there's a lot of research linking higher ACE scores to higher incidence of cancer in particular communities or populations. So when you're trying to make your case for developing these type of programs in your communities, you can make this bigger case that it's about kind of life course health and intergenerational family health. There are some critiques, so it's always good when you're talking about certain developments to also see if people are writing some alternative viewpoints. And there are some books and some publications coming out just about some cautions in how we critically or uncritically take up different ways of looking at things. And there's one book I found by Lagrenzi and Umilta called Neuromania on the Limits of Brain Science. So we read about this with technology too, is we're at that point where there's a lot of technology coming at us and we often don't have time to think about it from a critical perspective, from a moral or ethical perspective. But some of the cautions that I could find in the literature related to brain science were just to just be careful with not kind of overclaiming or oversimplifying, which when you try to take very complicated physiological science and so on and turn it into a message that makes sense for parents, there is a risk that you might oversimplify. So for example, we had a whole wave of parents who were really interested in providing all this extra stimulation to their children in the early years, where we know that necessarily, you don't necessarily have to do those things to support your child's attachment and brain growth. There's some concerns that people will think that if they're having these early challenges, there might be permanent damage. And again, we all have a potential to develop capacity across our life course. So we want to make sure people know that it's important to still have services for teenagers, still have services for young adults. Essentializing mother-child relations and reducing how we connect to our children as simply biological, when we know that there is that emotional connection that is unexplainable, and we don't want to lose that human connection as well. There is a risk of making value judgments about the right sorts of parents or mothers, to be surveilling more than less. And a lot of times those types of approaches tend to disproportionately focus on more vulnerable communities. And we have to be very mindful of how things are rolled out and interpreted. Again, it can position this intensive attachment work primarily the responsibility of the mother, and it can take us away from thinking about the value of a supportive community, the environment within which this family work is being done. So I think it can be a lot more expedient to say we have this type of program. Yes, we've done it, versus looking looking in depth at our communities and what some of the challenges we have in our environment in creating support for families. A bit of a couple articles I found that were showing that increased attention to disadvantaged backgrounds early on, if inappropriately connected to child protection and making reports. And some of this is showing up in the UK, where they've had some different initiatives in their in the child welfare field for a while, is that they are starting to see increases in children going into care. So have to very carefully think through what the pathways are going to be looking like. And finally, a very cautioning comment about eugenics just being back in some new clothes as we start to think about creating perfect babies, creating perfect families. So that's a caution for us as well. Just mentioned this briefly a moment ago, but a couple pathways. And I think in many of our communities, we tend to take the first pathway, where we are blaming and shaming when it comes to substance use in particular, which then leads to particular types of surveillance and risk assessments, punishments and child removal. And a lot of the legislation can kind of flow you that way as well. But there's a lot of research that shows us that the second pathway, where you take this holistic approach informed by determinants of health, by these integrated frameworks, where you really are strengthening community and services to wrap around families and build their capacities and strengthen their resilience, gives you that much more potential for greater lifelong thriving life. And so that's a bit of a flip. So how can we create that more supportive, resilience-oriented framework in our communities? Just connecting that resilience and trauma. This is here in Texas, Social Work Texas, and some of you online might have even been involved with developing this. And you can see that under, for example, prenatal and birth and well checks, prenatal care, to be trauma informed, to be thinking about conditions of daily living and supporting families with meeting basic needs and reducing stress. These things all cycle around. There's no necessarily a beginning or an end, that universal symbol. So some things in my last 2 minutes: what can we do with our everyday care? These are just a couple beginning ideas, but a lot of people are going back to their teams, looking at the data, looking at these frameworks, and thinking about what they can do in their communities, but thinking about how you can address stress and promote parental confidence in their care, no matter what part of the system you're working in. Integrating this trauma-informed, non-stigmatizing approach as part of your universal precaution to supporting families, and to do that work together. Thinking that many of your families will have many social challenges that they're dealing with. And of course, even just having a baby in the NICU for any period of time creates a real financial hardship, which can be a tipping point over for many families. So really connecting with your community partners in different ways. And you can see, welcome in diverse team members. We've not been really good in the neonatal unit to think about who are some very creative partners that we can have. Inviting in our community health nurses who work very closely with families. Looking at our mental health and substance use counselors, if you have a large number of families in your obstetric service who are dealing with mental health and substance use, why not integrate those type of team members into your composition? Keeping yourself well so that you can be bringing yourself in a good way to supporting your clients. And also, there's so much emerging now in fields of mental health and substance use and brain science, finding a way to make sure you're staying up to date, hence diverse team partners who can bring that knowledge with them, so that we can really be integrating our own models of care as well. These are just some of the networks I found in your state. Trauma resilience ACE networks are popping up all over the place. Often you'll find them with your child serving early childhood or child welfare agencies, but I don't know if any of you are connected to or involved in any of these organizations, but there are a couple starts for you. And I just put a point in about ensuring that these coalitions really represent different levels of society, diverse family structures, so that you really truly can be reflective of your communities. And that is my lovely downtown in Victoria. And we're sadly missing our American visitors because our border is still closed, but you never know, maybe this summer. So that is the end here, and I'll pause. And however you want to run any questions, I can, happy to take questions.
Somebody in the chat says, working with trauma immigrant child that doesn't have mom or dad, can this be adapted to the children in the centers?
Yes, these are highly adaptable principles. And I think if you go on to, I can find it later and send it out. There are some national child trauma organizations, and they have documents, I think, that would relate to that context. I work a lot with child protection and foster care and adoptive parents. And so it's all really translatable as well. And for workers working in all those settings, it would be very helpful principles, I would think.
Somebody had a comment that the Texas Association of Community Health Centers is also working on a trauma-informed program to all community health centers across the state of Texas. And then they provided the website as tachc.org.
Thanks, Amy. That was a whirlwind. We could probably do like many sessions, but I hope it's kind of sparked some interest in some different areas of research and science that are highly applicable to our practice, I think, and give you some new things to put in your practice tool belts.
Well, we really appreciate you coming and speaking today and providing all this wonderful information. And if anybody has any questions after this, once they get to review your slides, I'll just have them reach out to you.
Sure, I'm happy to get emails. Email me anytime.
Thank you so much. And everybody else have a wonderful day.